Thank you. Thank you all for joining us. Again, as you know, we began this conversation in December. This time, though, we have an opportunity to hear from the guy right in the crosshairs of everything happening on the Hill with health care legislation.
Can we rephrase that? Sort of the center of the universe would perhaps be a better way.
Dr. Burgess, as you've heard, of course, plays an important legislative role, but let's remember that he was first Dr. Burgess. He is the oldest, longest-serving doctor in the House, right?
Yeah, Phil Rowe is considerably older than I am.
So you come with such perspective, and so much has happened since we started this conversation in December. So much has happened, of course, about ACA, as well as, of course, the president starting out with his first address to Congress, talking about drug pricing, among other issues as well. We finally saw the FDA guidelines for the biosimilars, and of course, Dr. Gottlieb being named just last week. So much is happening, and here you are right at the center of it. But given the past few days, healthcare is back right front and center again. I think we should just start with just a view from your perch on where we're at with repeal and replacement and what's happening now. Can you give me your perspective on where we're going right now?
Sure, I'll be glad to. But can I just say first off, thank you for letting me be part of this conversation this morning. Last night, as I was trying to make sure I had everything finalized in our discussion this morning, in the Washington Post, there was an obituary for Lloyd Conover. Died at age of 93, and he was the individual who, when working for Pfizer some 65 years ago, figured out how to tweak the auramycin molecule and make tetracycline, which really impacted the practice of medicine then for decades. So since our subject this morning is the next drugs, I think it's useful to remember kind of where we've been literally in a lifetime. How things have changed, and when I think about things that have changed in the practice of medicine in my professional lifetime, it's nothing less than startling. So the Affordable Care Act, or the American Health Care Act, or whatever the next iteration, for those of you who were sleep challenged last Wednesday night, you were able to watch us do the 27-hour markup in the Energy and Commerce Committee. Ways and Means also did a similar lengthy markup dealing with the tax pieces in the Affordable Care Act. Both of those two bills, which passed out of committee, every Republican voted in favor of those bills, and it was a party line vote in both committees. Those two bills will be stitched together tomorrow in the House Budget Committee, and no good deed goes unpunished, and I will get it again in the Rules Committee the following week, and we'll probably spend a similar length of time debating it in the Rules Committee. Will things change between now and then? Oh, they always do. I can't tell you what precisely will change, and certainly there are conversations going on all over town to try to get people in a good place or a better place in regards to the bill. I do recognize.
On the specific point of whether there can be change, I mean, after the CBO report, do you see something that perhaps you wouldn't have seen last week that you think, okay, maybe this is a particular concern of your own?
Yeah, I don't think I can identify that for you. I mean, obviously, each individual member of Congress has their own concerns as they go forward, and they're voicing those. Leadership is, to their credit, listening. But, backing up a little bit, when Paul Ryan became Speaker in October of 2015, and remember at that point, on the Republican side, you had 17 people who were running for the presidential nomination, so it was not affirming any individual nominee's goals or ideals. But new Speaker Ryan at that time said, we're going to be for stuff. We're not just going to be against stuff. And he tasked all of us, going back to the basic backbenchers on the committees and just in the general House of Representatives, we need your best ideas, bring them forward. We did that over a year's time. He put together the Better Way agenda. Arguably, we ran on that in October of 2016. We won on that in November of 2016. And as the Speaker is fond of telling us, it's now our job to implement in this part of 2017. So that's where the process is right now. Again, could things change? Yes, they always do, but right now I'm not prepared to identify for you what those changes could or would or should be. I think there are a variety of ideas out there. And again, leadership, to their credit, is listening to those ideas.
But you're open to that. You're open to changes in what came through committee?
Realistically, I cast a vote for what was the product that was before the committee at the end of the 27-hour hearing. So I'm not in favor of seeing wholesale changes, but as I pointed out, I will get to vote for everything again at the Rules Committee. So I'm anxious to listen to the ideas that people are going to bring forward.
I should say also that people have identified you as the quarterback for what's happening on this legislation, but we'll see where that goes.
Probably over assumes, but we'll go with that for right now.
All right. So, of course, we know that biologics, and particularly the BPCIA, was originally attached to the ACA. Are there changes to BPCIA in this new legislation? Did it need it?
Well, I think you and Chip outlined this very well in his opening remarks. The whole concept of interchangeability and the Food and Drug Administration postponing or prolonging the length of time the comment period is open on that. I think that's reasonable. You know, and I think back, I cannot believe this is the third FDA reauthorization that I will have lived through in my time on Capitol Hill. It seems, when it first happened, it seems like this is something that only happens just once in a lifetime. And now here we are on number 3. Every single one, every single reauthorization of the user fee agreements that I have been involved with, 2007, the House had just changed from Republican majority to Democratic majority. Oh my gosh, what does that mean? What does that mean for the user fee agreements going forward? It got done. There were some things obviously that I disagreed with, but it got done. And then in 2011, we had a terrible fight over the debt limit. No one thought that in a year's time we could come together on user fee agreements and that Republicans and the president would agree with anything, but we did, and we got it done way ahead of schedule. No one remembers the bill signing because it was in the broom closet off the Oval Office. The president didn't want to be seen with us. We didn't want to be seen with him. It was an election year, but the work got done. And I think that, you know, if there's anything that I've taken away through my tenure on the Energy and Commerce Committee is we can occasionally put our weapons down and do the right thing for the American people. I would say the FDA Safety Improvement Act of 2012 was one of those times. And we're now involved in that again. The subcommittee that I now chair, yeah, we've got the Affordable Care Act and we've dealt with that. We've already had one hearing on both generic drug user fee agreements and the biosimilar user fee agreements. We will continue with an aggressive hearing schedule. We will get the work done, and it will be done in plenty of time, just as it was in 2012. So
because the expiration is, I believe, this fall, this September, right?
End of the fiscal year, but the FDA, because of hiring practices and notifications, we really need to have our work. July is the time frame that we need to work with, and we will. I mean, I think there's no question the committee is cognizant of that. So will there be improvements? I hope so, but it is, if I understand the role of the subcommittee on the user fee agreements, those agreements are struck between the agency and the industry, and we are to oversee that process and ratify that process at the end of the day if it's acceptable. The fact, and again, Chip's opening comments, the fact that there have only been 4 approvals and 2 marketable items, I think if there's one thing that came up in our hearing last time, it was the concept that we need to do something so that we get to talk about more biosimilars the next time we're up for a reauthorization. My old major professor at Parkland Hospital used to say a difference, in order to be a difference, has to make a difference. Well, in this case, if we're going to make a difference, it's going to be more of these types of approvals that have to occur. And as came up in the hearing last week or 2 weeks ago, the concept of that things need to be able to be approved on their first run. It can't be, you have to come back, you have to come back, you have to come back. So the predictability, if there's one big takeaway that I took from that hearing, the predictability of the process really has to be firm. And so that obviously is one of the things that we're looking for in the reauthorization of the user fee. I guess the last part is the commitment on the part of the agency to staffing, and that is going to be one of the things that we will be looking at quite intensely. Again, this is a different landscape for these user fee agreements because we have a new administration, and as of this weekend, we have a new designee for the Food and Drug Administration, someone who I'll just say I think I can work with. I've had I've known Dr. Gottlieb for some time, and although we don't agree on everything, we agree on enough that I think I can say with confidence that we will be able to work together. And I think there is broad recognition that this is just something we need to get done.
Both the President and Dr. Gottlieb have talked about this, trying to streamline the process for FDA. Do you see opportunities there that perhaps didn't exist just a few months ago? Do you see something that's going to change and that is going to spur? And I mean, as we have been very clear, there are only 4 drugs that have made it through. Do you see a real sea change here, an opportunity that will come this year?
Well, I'm always an optimist, so yes, and I do think a streamlining of some of the activities, and again, we heard about that during our hearing, and I think the landscape is correct for that. I don't want to be political, and I certainly don't want to disparage a federal agency over which I have jurisdiction, but I will confess there have been times it has been tough. Since the last user fee agreements were signed, actions were taken by the agency and the administration that just made things more onerous, more difficult. I'm hopeful that those types of things won't be occurring in going forward from this user fee agreement.
What role do you see Congress playing at this point, specifically with reference to the biologics? I mean, what understanding needs to take place there?
Well, we do need to understand the agreements that are currently being ironed out. We need to understand why the concerns are what they are. But on the other side, you don't want your member of Congress deciding which biosimilars get approved and go to market. So there's a dichotomy there, and it's. And I'm certainly cognizant of that. There is no shortage of people who will come in and talk to me about tales of woe they're having with the agency, but it's not my job as a member of Congress to make that pathway, to make that particular drug or that particular pathway work better. But in general, I do want the agency I want it to increase efficiency. Great, we had our first biosimilar agreement in the last user fee agreements that were crafted in 2012. That's a start, but the fact that only 4 were approved and 2 are commercially available, certainly the report card for this next iteration of the biosimilar user fee agreement has to be a significantly increased number of products. And again, I think it was said during the opening remarks, I mean, you're not just doing this because it's a clever exercise to create biosimilars. You're doing this so that the effect on the market will be for the ability to treat more patients at lower cost, and ultimately that is a good thing. And that is clearly, I think, the goal that has to be kept in mind at the subcommittee level.
Okay. I want to encourage those of you who have questions, and I know there must be many because you don't often get a chance to talk directly to the man who's at the center of these conversations. But if you have questions, I encourage you to point yourselves out to our folks with microphone out there.
I can point out I'm nothing if not accessible.
Well, that's a very important thing, and you certainly made yourself available to us today. Can you talk a bit about the understanding, one thing that was said earlier, I think Chip said earlier, is that this maybe is not the conversation that laymen have right now, that the general public understands about the importance of biologics and the potentiality of this market in our healthcare today. Can you think to speaking to your constituents, to those of us who are laymen, about where we are at and what the potential is for biosimilars?
Well, let me even take a step further back than that. And I do remember when generics in the small molecule space first occurred, and I was a practicing physician, and I thought, by golly, you'll prescribe what I write down, and there'll be no changes from that. So I was fairly rigidly adherent to what I had learned, what I had known, and by golly, if I wrote down a name, that's what I wanted dispensed. And
you wanted your patient to get that.
That's exactly right. Cost considerations probably didn't have the intensity that they do today, so that wasn't really a driver. It's simply the fact that I knew best, and no one should second guess my judgment. And many times I do feel the same way today. I think what I hear from patients today, what they want is, pricing is important to them, but they want the certainty. My doctor said I needed this, so you're telling me that you're going to give me that. I want the certainty that it is the same product and will achieve the same result, and that I'm not being treated with something that's less expensive with a lowered expectation that I'll achieve the desired result. So I think that is to the extent that patients are engaged in this currently, that's the feedback that I get.
But you know, I mean, for me as a patient, I look at it and say, okay, over a couple decades, I've finally been persuaded that the generics, the small molecule drug, all right, we know this is interchangeable. I'm convinced, my doctor's convinced, I'm convinced. We're going to a different hurdle, though, with the biosimilars. And what do you see as the challenge there for physicians speaking to patients and helping them to understand, is the government sure this is safe? The efficacy question, how tough is this?
Well, that's the criticality of the agency getting it right, and subsequently the agency being believable when they say product A, product B are in fact able to be used on this condition with no regard to efficacy or outcome, and then price becomes the only additional consideration. Will that record be established? And I think there's still an unknown at this point. Do the guidelines get us there? I think they do. But again, I don't want to minimize and some days I am critical of the FDA. I know it's a big surprise to everyone here. But I want them to do their job, and I want them to have the credibility going forward. Their mission is that things be safe and effective, and that is, I want them to fulfill that mission. I want them to have the tools that they need to be able to do that in a timely fashion and actually I want them to get approvals done. I don't want them to approve something if it's questionable.
But the interchangeability question is still going to be challenging in the biosimilar market because this is a different.
Correct. And the accumulation of data over time will either prove that okay or less than okay. And that, again, that's the criticality of the agency making the right decisions and the right choices, and the criticality of us at the committee level, at the congressional level, making sure they have the tools to do just that. If the staffing is a consideration, then I want the agency to talk to me about the staffing. We heard about it in the hearing that we had. If the agency has identified another problem where things are not getting approved on the first run, we need to know from the agency what can be done to help that so that people are not having to have serial submissions of their product.
Just before you, yes, ma'am.
Morning, Congressman. Oh, thank you. I'm Susan Campbell with Women Heart, and in the beginning of the conversation, you talked about the American Health Care Act, and there's a question about coverage, and the president has said that in the bill that comes out, everyone will be covered, and the CBO has cast some doubt on that. What are your thoughts on that?
Well, obviously, that's the big discussion right now, and the CBO, for whatever reason, feels that if there's not an individual mandate, people won't take insurance even if it's free. I don't know that I completely agree with that assignment, but that's the challenge now in front of us.
Hi, I'm Larry Lamott. I'm representing the Patients for Biologic Safety and Access, which is a 24-member organization of national patient advocacy organizations, and who are concerned about the safety and efficacy of biosimilars. And there's a couple of things that I just wanted to get a clarification on. There's been a couple of references this morning already about there's only 4 who have been approved, and there's the inference that that it should be speeding up and getting faster and faster. But with the understaffing at the agency and the expectation of more and more with less and less people, how does that get resolved in terms of making sure that we don't take shortcuts in the approval of biosimilars, that they will go through a rigorous process? That's one. And the other question is dealing with...
Can we deal with that one first
Sure.
then? And that's in the inherent trust of the agency. I don't think there's any question that we all want the agency to perform efficiently. We certainly don't want them to not use resources in a wise way. I do have, since I know Dr. Gottlieb, I know him to be someone who is concerned about the efficiency of the agency, and I think he will put a lot of attention on that in his tenure going forward. But the concept of just approving things because we want to increase the approval rates, I don't think anyone is asking for that.
And the second question I had was really dealing with interchangeability and the whole issues of non-medical switching. We have, you all, Congress, approved this measure with a standard of interchangeability, which is a different standard than any place else in the world. And made the references that automatic switching can only occur if it is deemed to be interchangeable. And what we're finding, PBSA and others are finding, is that even though we don't have any interchangeable products on the market yet, that providers are forcing automatic switching by changing their formularies and not giving any choices to people. And it seems to fly in the face of the law. And I'm just wondering what you in Congress can do to make sure that only if it's interchangeable can there be a switch.
Well, first off, the extending the comment period of additional time, I thought was a reasonable step. If there is still some concern about the notion of interchangeability, let's be sure that we have that definition correct, and it's one that people can actually work with. I will tell you, I haven't looked into the part that you referenced on the issue of not so much providers. I guess it's a coverage determination by companies who provide coverage. So clearly that has to be part of the equation as well.
Yeah, I'm sorry, I didn't mean providers. I meant the payers who are already like CVS and others who are already
Correct.
changing their formularies and taking reference products off the formulary.
I trust providers. That's why I took umbrage at that designation. Doctors are always going to make the right decisions, and I just stipulate that as I get up every morning. I will look into the other aspect. It wasn't something that actually that came up in our hearing 2 weeks ago.
Great. Well, that's a good opportunity for you to go to the Hill and bring the voice of our folks here.
Listen and
in the
learn.
conversation. Thank you so much. I know that you have to get up to the Hill. I know that there is a lot of work going on. I appreciate your being here with us, Dr. Burgess.
All right, thank you so much for the time.